You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. I'm here with colleague friend, Dr. Sarah Spelsberg. She is a co-host on the World Extreme Medicine podcast and indeed a friend. Sarah, welcome to the podcast.
Thank you so much for having me, Owen. I love this podcast. I'm so happy to be here.
And we're just going to unpack one of your blogs today, and it's a fantastic piece around the magic of point of care ultrasound in remote medicine. And you've written this fantastic blog. It'll be in the show notes for people to go away and read. You're going to hear the AI translation of the blog a bit later. But Sarah, I just wondered if you'd speak to the piece initially.
Absolutely. So I wrote this just out of profound gratitude for my Butterfly Ultrasound. Uh, and I used it a lot out in Alaska in a very remote area. So I don't have CT scanners and I have limited X-ray. And so having another imaging tool was just invaluable for us. But when it really, why I wrote the piece was because we had a literal boatload, like a boat of like 119 people on a fishing processing vessel come in, and COVID had ransacked the entire crew. 95 of them were positive, and I had to dress in a spacesuit, like a hazmat spacesuit, to take care of them. So I can't really use my stethoscope. I can't listen to their lungs. I'm very limited in the amount of physical exam I can really do. And so I was so grateful to have the little portable Butterfly ultrasound, because I had them self-select for who was sickest. And we set up a clinic on the dock, so we weren't bringing sick people through the town and exposing the rest of the town or the rest of the staff at the clinic to it. So it was mainly just me at the point of this. And using the ultrasound, I was able to say, okay, your lungs are pretty clear. Your lungs are pretty clear. You're okay. 30 of them were sort of iffy. 6 of them were like, this person needs to be prioritized for who goes first to the hospital. And 3 of them, I said, once we get, if we can't medevac this person needs to go straight to the hospital once we sort out how we're going to medevac 119 people from an island in the middle of the Bering Sea to the mainland. And we ended up Anne Zank, our Surgeon General of Alaska, is just brilliant, and she worked with the head of our little clinic out there, and they came up with a plan to take everyone by boat. And so the fishing company hired in paramedics to be on the boat, and they hugged the coastline and went to Seward because there was no dock space in Anchorage. From Seward, they were bused up to a hotel, and then from there they went as they were prioritized to the hospital. But the ones who had the most dramatic looking lungs with the Butterfly ultrasound were the 3 who ended up in the ICU. And the 6 people who had, not quite as bad, but not great lungs, like ended up in the hospital as well. And so it was just an invaluable tool that I wouldn't have had otherwise, to help at least triage and stratify these people based on their risk profile and get them the care that they needed as quickly as possible. And then there's one other time when it was really hit home, the importance of having point of care ultrasound in the field. And that was actually one of my staff had a fever, was short of breath, and was tachycardic, like starting to look like sepsis. And the chest x-ray was negative. And like the rest of the workup's negative. And I threw the ultrasound on her lungs, and very clearly you could see like an area that looked like a consolidation. And so from that, I said, you know what, we're putting you on antibiotics. We're not going to call this a virus. Like, this is enough for me. And she started getting better right away with aggressive antibiotic therapy. And I do believe that it found a pneumonia that was 100% missed on chest x-ray. And so I just think the value of having point of care ultrasound when available in remote areas, it's just worth its weight in gold.
Yeah, absolutely. And to your point, you can use it as a triage adjunct, and especially like you say, when you can't necessarily put anything in your ears because you're wearing a hazmat suit, you're wearing
Mm-hmm.
maybe a full goggle and masks, and it's,
Yeah.
that's just not available to you. But also you speak to in the piece really, not only the ease of use, but the accessibility now of training. It's become, like you said, an accepted standard of care. And actually, even in remote medicine and indeed on expedition medicine, it's actually finding its way into expedition medicine, not only within established pre-hospital care, but like you said, in remote and rural medicine, and it's actually. Like you said, sometimes an amazing triage tool in these environments for contemporaneous real-time images that you can't necessarily get from any other device. And in a way, like you said, it should almost become a standard of care on expedition, I think, because devices are becoming cheaper, battery life is becoming better. But just before we hear the piece, could I get you to speak to any further reflections you've had since you've written the piece?
Absolutely. It's something I use as often as I use my stethoscope. I walk around with it in my pocket in the hospital. I took it with me to Fiji and used it almost every day there. And then the other thing is like, for gallbladder pathology or abdominal pain, I've used it to see a ruptured appendix. I've used it to see confirm someone's IUD didn't fall out. I've used it to look at gallbladder pathology and tell whether or not someone had stones, tell whether the gallbladder, the common bile duct was dilated or not. And so, to what we've spoken of before, also the pericarditis and the pericardial effusion, you can use it for that. You can estimate an ejection fraction. I mean, just as well as like just fluid status on rounds. Like, are you dehydrated or not? And can you talk? Is a fluid bolus what you need, or are you overloaded, but you're just putting it in the wrong space? And so it's just an invaluable tool. I use it every day. And as far as on expedition, I've tested it in some pretty harsh environments, both cold and hot. And the phone or the iPad will fail before the Butterfly does. And so
Yeah.
it works in these remote environments if you take good care of it.
Yeah, it's profound. It's profound. Sarah, listen, thank you. Just about to hear the blog. You actually also going to have the blog post in the show notes to go away and read. It's a fantastic read. I do encourage you to go away and read it. So it's always a pleasure. Thank you.
Thank you so much. I appreciate it.
Welcome back to the Deep Dive. Today we're exploring something of a quiet revolution in emergency medicine. It's all centered around a technology that's, well, surprisingly small, surprisingly affordable, and performing what seems like medical magic in some of the most isolated places on Earth. We're diving into point of care ultrasound, or POCUS, and the story for this deep dive is grounded in the experience of a doctor on the island of Unalaska. I mean, think about that location for a moment. It's smack in the middle of the Bering Sea, an astonishing 1,000 miles from what you or I would call a real hospital.
And that extreme isolation is exactly why this matters to you. If we connect this to the bigger picture, what we're really tracking here is how POCUS, which has historically been, locked behind massive infrastructure, is becoming the essential tool when advanced imaging is just unreachable. Our mission today is to understand not just the potential, but the very real practical application of how a single pocket-sized device can overcome these huge historical, geographical, and financial barriers to save lives.
Okay, let's unpack this then. And I think we need to start by understanding those roadblocks, because before POCUS could become, pocket-sized and essential in the Bering Sea, it had to overcome some pretty significant resistance.
Right. That context is absolutely vital. Back in 2016, there was a key study by Rogers and his colleagues that looked specifically at rural emergency departments, and it outlined so many obstacles. And they weren't just about cost. I mean, they included things like the difficulty for medical staff to maintain their skills when they just weren't using the equipment that often.
Right, the whole use it or lose it problem.
Exactly. And there was a slow uptake of the technology in these remote areas, chronic funding issues, of course, and then huge challenges with quality assurance, when there's no specialist nearby to double-check your work.
That sounds like a cycle that just feeds on itself.
Mm-hmm.
If you don't use it, you lose the skill. If you aren't confident, you won't use it. And if nobody's using it, why would a funding body ever prioritize it?
Precisely. And in a place like Unalaska, those challenges are just exponential. I mean, imagine trying to stay proficient in a skill you might use maybe twice a year, 1,000 miles from the nearest training course or specialist mentor. Historically, that kind of isolation didn't just mean a slow diagnosis. It meant a diagnostic black hole.
So, if it was so hard to get POCUS adopted in rural places, Why was it becoming such a staple in big city ERs at the same time? Was it purely a cost thing, or is there some kind of medical inertia keeping it contained?
It was a mix, but a lot of it was inertia. In the large centers, POCUS was already indispensable because the benefits were so clear, so immediate. For example, it lets you diagnose things like a pleural effusion, that's fluid around the lungs, or developing pneumonia. Even when the finding is so small it wouldn't show up clearly on a standard X-ray, it gives you this real-time visual information that, blood tests and even X-rays can often miss in those early stages.
And for abdominal issues, it's kind of a superstar, right?
Oh, absolutely. The gallbladder is really the gold standard for POCUS imaging. A patient comes in with that classic right upper quadrant pain, and the ultrasound can give you a crystal clear look at the wall thickness, which tells you about inflammation, or it can show you stones. You get an immediate, actionable diagnosis right there, instead of waiting hours for a CT scan.
What's really encouraging, though, is that the source material points to this massive educational shift. It's basically solving that skill barrier before it can even start.
And that's the long-term fix. The trend toward normalization is profound. Most residencies now offer ultrasound electives, sure, but the real change is happening in medical schools. Some are now requiring POCUS training. They're treating it exactly like they require a student to own and use a stethoscope.
We're seeing that democratization happens so fast. The sources mentioned that some medical schools are just handing out devices. They give students something like the Butterfly Ultrasound on the very first day of class. The idea is to get them to just play with it, to make it normal, and integrate it into the physical exam from day one.
And that shift from a specialized skill you learn years into your career to a basic tool you get on day one, that is what unlocks the potential for remote medicine. It means the next generation of doctors showing up in Alaska will see this not as some exotic tech, but as a standard, necessary piece of their kit.
Which brings us right back to the doctor in Alaska. She saw this coming, especially with the early news about the coronavirus spreading and the promise of using lung ultrasound to quickly triage patients. She knew she couldn't wait for the institution to fund it.
This was a commitment driven by pure necessity, not some hospital budget line. She literally, as the source says, bit the bullet. She paid for part of the device herself and then fundraised for the rest just to get this tech into her clinic. It speaks volumes about the kind of independence you need to practice medicine 1,000 miles from anywhere.
And the cost is maybe the most revolutionary part of this story. The device itself, the Butterfly Ultrasound, was about $2,000. That is a tiny fraction of what a traditional cart-based ultrasound machine costs. Those can run over $250,000 and need their own room.
Right, and critically, the training membership, which gives you all the online videos and support you need to keep your skills sharp, is only about $500 a year. You're basically paying the price of a decent laptop for a diagnostic power that used to require massive infrastructure.
The sources also make it clear that this doctor was actually a novice when it came to POCUS, which, raises the big question, how did she get good enough, fast enough, to use it when lives were actually on the line?
And that's where the accessibility of the model just shines. The only formal training she used were these short, clear instructional videos on the Butterfly Inc. website, which she got with that subscription. That, combined with just the desire to, as she put it, play with her new toy.
She called it a toy. That says so much about this new culture in medicine, where the tools are intuitive and learning is self-directed. According to her, the device was easy to use, and the online training was remarkably clear. That easy entry point just removes a massive hurdle for rural doctors who don't have specialist training teams down the hall.
And this ease of use translated directly into confidence. In a remote setting where you're the only decision maker, confidence isn't just, a feeling, it's an ethical weight. The doctor mentioned that before she felt secure, she'd do the post-CS exam off the books. She'd tell patients, you won't be charged for this, but I just want to take a look.
And she only started formally integrating it into care and, charging for it when she felt totally secure in her ability.
Exactly. And even now, it's her personal, immediate tool. She keeps it in her right side cargo pocket, treating it like a stethoscope, always there, always ready. That physical closeness and instant availability, it completely changes the workflow. She doesn't have to call a tech or wheel in a giant cart. The diagnostic window is literally in her pocket.
Okay, here is where it gets really interesting. Let's move past the theory and the training and look at 3 specific high-stakes cases where this little pocket-sized device gave information that otherwise would have required a $90,000 flight.
These are the real-world examples of POCUS being a life-saving tiebreaker.
All right, case study number 1. the maiden voyage pneumonia. A patient comes in looking, well, quite ill, short of breath, fever, pain in their lower left chest. So traditionally, you're leaning on the X-ray in the labs. The chest X-ray was read as definitively negative, not just by the staff on site, but also on the radiologist's official overread later.
And not only that, but the blood work was misleading too. The patient had no elevation in their white blood cell count. That's the classic signal that the body is fighting a big bacterial infection. So by all the traditional metrics, this patient did not meet the criteria for a severe infection.
Wait, so the gold standards, the X-ray and the labs, both basically gave the all clear, but the patient was obviously sick.
That's the failure point of the old system. An X-ray is just limited in showing those very early or subtle consolidations in the lung.
But the POCUS device saw it. The doctor put the butterfly probe right on the spot where it hurt the most. And despite that clean X-ray, the device showed a developing pneumonia, clear as day. Because of that immediate real-time insight, they started IV antibiotics right away. And the outcome was dramatic. The patient felt much better the very next day and was back to normal within 3 days. A miss there, 1,000 miles from care, could have been a catastrophe.
The POCUS didn't just confirm a suspicion, it overturned a false negative from the standard imaging. That is a truly revolutionary capability in a remote setting.
Okay, case study number 2. This one involves a massive heart attack, and it happened when the doctor was just, in her words, playing with the device. She used it to look at the patient's heart and saw something alarming right away. Decreased wall motion.
That visual finding was a stunning immediate warning sign. And clinically, it matched up. The patient had a troponin level of 15.
A troponin of 15, which, for anyone who isn't deep into cardiology labs, that means they are well into catastrophic heart attack territory, right? That's indicating massive damage to the heart muscle.
Massive. When those levels are that high, it's a time-critical life-or-death situation. Getting that patient to a cardiac cath lab is the only option.
But the really invaluable role of the POCUS here was twofold. First, instant diagnosis. Second, the doctor was able to use the video of the patient's own struggling heart to convince them they needed to take that medevac immediately to get to tertiary care.
Yes, that personal visual confirmation, seeing your own heart struggling to beat it, often overcomes a patient's natural resistance to leaving home, to facing the cost, to taking a risky flight. In this case, the POCUS video saved that patient's life not just through diagnosis, but through persuasion.
And finally, case study number 3. Acute cholecystitis, a seriously inflamed gallbladder. The patient had classic symptoms: pain in the upper right abdomen, and blood tests showed an elevated white blood cell count of 14,000 and a bili of 1.6.
And just for context, that elevated WBC suggests a big infection. And the bilirubin, the B-spur, at 1.6 suggests the liver is starting to get stressed out from an obstruction or inflammation.
The POCUS scan gave them the missing piece of physical evidence. It showed a significantly thickened gallbladder wall. That's a very strong visual sign of serious escalating inflammation.
And that finding proved absolutely crucial the next day. The patient got worse. They came back, and their white count had jumped to 19,000, a clear sign of a rapidly worsening infection, maybe even sepsis. So that combination, the POCUS visual and the deteriorating labs, that's what helped convince the patient that this was an emergency that needed immediate surgery.
The patient traveled for gallbladder removal, which was definitely necessary to prevent a life-threatening septic event.
And if we connect all 3 of these cases, there's one capability we really have to highlight, and that's communication. That 1,000-mile gap between the clinic and the specialist, it's instantly bridged. The doctor can text or email a short video clip of the exam, the pneumonia, the compromised heart, the thickened gallbladder wall directly to the patient, to another ER, to a specialist hundreds of miles away. It turns the diagnosis into this shareable, verifiable piece of evidence.
What's so fascinating here is the overlap between medical risk and financial risk that this, $2,000 tool helps manage every single day.
Absolutely. The medical risk is huge. Sepsis is a massive threat even in the best hospitals. But when you're dealing with a patient who could be septic 1,000 miles from a surgeon, the decisions you have to make about transport are just monumental.
And that is where the financial risk becomes very, very real. For a patient who can't fly commercial because they're too unstable, like the heart attack patient, the only option is a medevac.
Right.
We're talking about an expense that can easily top $90,000.
POCUS provides the objective visual data you need to decide, with a high degree of confidence, whether a patient needs that astronomically expensive medevac or if they're stable enough to fly commercial. You're managing resources and risk at the same time. It takes some of the guesswork, the pure clinical gut feeling, out of these high-stakes, high-cost decisions.
The doctor's final thought on the device's potential just shows how quickly this tech is moving and how much is still possible. She says, "I just wish I could find a way to see the brain with it."
And that wish, that's the engine of medical progress, isn't it? It shows that once you put a powerful, affordable tool in the hands of a general practitioner, they immediately start finding ways to push the boundaries even further.
So what does this all mean? I think the fundamental takeaway is a really powerful story of mitigating risk and enhancing capability. A $2,000 device, plus some basic training that's now starting in medical school, can be a life-saving tool for everything from pneumonia that an X-ray misses to a massive heart attack. In these isolated areas, it cuts down on both high medical risk and huge financial expense. It pays for itself many, many times over with just one avoided medevac flight.
It really is the democratization of technology. We've watched POCUS move ultrasound from the centralized, specialized machine that needed huge investment to a pocket-sized device that a novice doctor can use in the Bering Sea. And this raises an important question for you, the learner, to think about. We all accept that certain diagnostics, like an MRI or complex gene sequencers, need a massive footprint and specialized staff. But what specific high-cost, specialized diagnostic tool that currently lives only inside a major hospital, the kind of machine that dictates where advanced care can even happen? What could be the next technology to experience this rapid miniaturization and distribution? What's next to fundamentally change healthcare access across the globe? It's a question that redefines what a clinic can be, anywhere on Earth.
Something to mull over until our next deep dive. Thanks for joining us.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.